So thank you for inviting me, Jaime, and thank you to our guests here once again for staying here with us. This conversation runs around a very singular concept. Can you hear me? Can you hear me?
Where's the microphone?
Hello, 1, 2, 3. Okay, all right. It's better. Okay, all right. So, which is normally we know the diseases. When you talk about acute myocardial infarction, you know what that is. When you're talking about a pneumonia, you know exactly what that is. When you talk about colon cancer, you know exactly what you're talking about. Post-viral syndromes are a unique area that has a higher degree of uncertainty that the normal practice of medicine, normal knowledge of medicine has, which raises very interesting problems and very singular problems as well, which is how am I going to show all the stakeholders, society, health professionals, patients, families, media, that this disease really exists. Normally when we talk about this, we are trying to defend a certain disease. Diabetes is very important, but we know exactly what it is. Everybody knows what that is. Here is different. And therefore, there is this huge amount of effort of trying to bring to upfront this, I would say, not new, because we've been talking about post-viral syndrome for the last 40 or 50 years. So it's new. It's not new at all. New is long COVID, but then again, SARS-CoV-2 is also new. But it's not new. It has been here forever. So we are now getting more aware of the existence of this disease. And since it's even the long COVID is a recent disease, but ME/CFS is a long disease, it's very interesting that when you look at pathophysiology, like we discussed so well this morning, it's really, really, really almost the same thing. For me, it was a surprise. I wasn't expecting this.
Right.
But it's an opportunity, a huge opportunity for the patients that are technically abandoned. Nobody believes them. They send to psychiatry and say, well, what? Suddenly, the landscape changed, and we have to take opportunity of this. This is a unique opportunity for several reasons. One of which is long COVID is really important disease. It's going to be more and more. You just have a couple of years. We have a lot of work to do for the next 5, 10, 15, 20, prognosis, short-term prognosis, long-term prognosis. Everything's going to be needed to do a huge amount of research on this, but also because we can drag together this type of diseases and lump them together and discuss them together. Now, there are several stakeholders that can actually assume that responsibility, and certainly the patients are one of them. That's why we organized this meeting, because this was organized basically by the patients. And so certainly they are very powerful, and if they are well organized, they are unbeatable. Nobody, I used to say, you guys, I invite, this meeting took about a year to organize. When the first time John talked to me, it was about a year ago. And so we decided to select these very, very high top quality people in the world. And I said to her, they're not going to come. Mm-hmm. They are very busy people. And she said, there are two groups of people in which these experts come. If the meetings are organized by patients or by medical students. And she was right. Mm-hmm. Because every single time that I invited you, you always said yes. So I'm really, really grateful. Uh-huh. And this part of our meeting today is just basically reflecting on, we know about the importance of patients. Let's now talk about the importance of doctors and healthcare professionals. I will even, go beyond doctors. What should we do? What is your experience in terms of trying to change things? With whom do you speak? Mm-hmm. What is good? What is a good idea that we should do on the short term, or on the long term? So I'll start with Susan. Dora has a major advantage. She is a patient, but she's also a doctor, so she understands this much better than most of the concept of this. So, Susan, if I was going to be a champion of this disease, of this pathology, what advices would you give us?
Well, yeah, obviously I've thought about this for a long time, and I always say that I've been doing this for 30 years plus, but things really haven't changed very much. And I think I've certainly learned so much in the last 3 decades of practice from my patients, and I've tried to hone down and so I thought I was going to interview Joan, actually. So I was going to demonstrate just my in-office interaction with my patient. So my first thing is, how did you get this? What were the circumstances under which you became sick? By that I mean, was it an acute event? Was there a trigger? Can we find something tangible that you can link to the onset of your illness? So that's one of my first questions. Sometimes it's obvious to the patient and sometimes not, but that's my sort of lead-in question. Dora, I'm going to answer your larger question in a minute, and then based on what I've learned about, and we know now a lot about comorbid disorders, frequently there's a clue elsewhere in the patient's history. Oh, I was perfectly healthy before this, but then you ask, did you have migraine headaches? Did you ever faint as a child on the baseball field, for instance? Did you ever have irritable bowel syndrome, or have you had allergies or eczema as a child? So these are risk factors, we think, that I've learned about through the last decade or so of studying this as part of a multi-center group that we've got going on in the US that's looking at potential risk factors for this. So I've sort of introduced that element into the practice based on what I've learned there. And so we sort of continue the conversation. But to answer your larger question about what my wish list for this illness is to really have it be something that's mandatory in the curriculum for medical students to learn about. And also, as part of postgraduate training, for instance, I trained in infectious disease, did my fellowship, as a mandatory rotation, because frequently we learn only about those immediate diseases like AIDS or something like that that's going to kill you right away, or meningitis, the more dramatic diseases. But these diseases, the chronic fatigue syndrome, ME/CFS among them, are stealthy. They just come upon you slowly, mysteriously, and then they take away your life. They take away your breath. But yet they're also invisible illnesses because everybody looks okay when they walk in the office. Their lab tests are mainly okay. So the main take-home thing is to really believe your patient about the symptoms, even in the absence of a positive blood test, to really take this journey with your patient and be willing to, surrender your sort of scientific need to have a positive test or, evidence-based medicine, but to query it and to take this journey with your patient, basically.
Thank you, Susan. Now, Dora, you have a special role here, in the sense that we just talked. If you want to make this disease more visible, with whom should we talk? Whatever you feel like, I need to do something about the overall picture of this, with whom should we talk?
It's very difficult, and I'm with a double paper here, yes. And Susan, if you want, you can ask me.
Oh, okay.
You can interview me as you will do with John.
Yeah.
It's very difficult for us as a patient, and I feel that because the psychiatric adjustment for us, it's huge. And I think everyone here in this class, in this room, has got that mark on their shoulders and their heads. And this disease has not a biomarker, has not a classification that we do, as you said, Professor, before, diabetes, age, we have got a lot of markers, as we do in Sjogren's syndrome, as we do in rheumatoid arthritis. We have got markers that we can do, that we can classify a patient. Here, we don't have any kind of markers. And if you correct me, Susan, if I'm wrong. And we need that to say to our patient, you've got this disease, and this is how we are going to treat you. In long COVID, we don't have that. And I, as a patient, feel that always. I try to ask help with internal medicine, my specialty, nothing happens. I try to help with my cardiologists, and I am a lucky girl, okay, because I had a marker. I had a myocarditis and I had a pleural effusion, okay? I'm a lucky one because I'm not crazy, okay? I think that's the difference, because I've got everything that you've got, but I also have got a case, a causal for my chest pain, my cardiac arrhythmics, okay, it's different. I'm the lucky one. But I don't have biomarkers also.
Let me ask you a question, if I might.
Yes.
When you were practicing and
Yes.
you encountered a patient with non-COVID ME/CFS, did you, not exactly write them off, but did you take them less seriously than you would now, having had it yourself? Do you know what I mean? Like once you experience...
I understand you. Yes.
Yeah.
My experience make me see different things now. Because COVID, I think COVID has turned all medicine around, everything. Mm-hmm. Because we saw now things different. 5 years ago, mm-hmm. Even though we know that other viruses like Epstein virus, like CSM viruses, do also a post-infectious mm-hmm.
fatigue
syndrome,
mm-hmm.
but not too long.
Right.
We now see this in our medicine, in our practice, and it turns out that even, and I don't think so, I think that probably less frequently we don't look at them with these eyes, but our elderly people have also COVID infections, and they are more fatigued, more difficult in walking, more difficult in doing their home things usually,
right, sure.
And we don't look them as a post-COVID syndrome. We say, oh, they are getting older, but they have also this syndrome.
Right.
Yes, I experienced that because this is a disease that we have got to be alert of.
Now, when you see let's say you go to your cardiologist and they don't know what to do with the myocarditis,
yes.
and you're just sort of dissatisfied with their care, do you kind of do your own research and
yes.
tell them, like, this
yes.
is what I found?
Yes. The first time I went to my cardiologist, I do an Holter. It's in a 24 hours ECG. Right. And my cardiologist tell me, Dora, you are freaking off. You've got to do a spa. You've got to do yoga because you've got a frequency of 115, wow. 2,000 to 200, sorry. And it's a Saturday morning. Why are you like that? You are freaking off. You've got to do yoga. You've got to do gym. You've got to work out. Okay. I said, okay. Oh. And she'd give me a beta blocker. Okay. Mm-hmm. 1 month after, she called me back, Dora, sorry, I went to a conference of cardiologists and they spoke the first time of the tachycardic paroxystic orthostatic, and you don't have nothing on your mind. You've got a post-COVID complication of myocarditis.
That's a good outcome.
Yes, it's a good outcome.
But at least you know what you have.
Yes.
Really important.
Yeah.
So they are afraid of the complications of the myocardic. Right. They don't know what to do. Yes. Mm-hmm. But I think it's not only here. I think it's worldwide, right? Yeah. And mm-hmm. I think that's why I'm here, and that's why I think it's very useful and it's very important for us to try to understand mm-hmm. what is the problem, what organs COVID affects, because it's not only the brain, it's also a neurological complication, cardiology complication, pulmonary complication, ophthalmologic complication, and I think we are way far away from the diagnosis and from the major complications and the treatment also.
So do you feel some satisfaction, well, at least with that doctor came around a little bit, But some of the other, like if you went to see a rheumatologist or if you saw a neurologist, would they do an MRI of the brain? Would they know what to do you think?
No. I find the best rheumatology I could have, Professor Jaime Branco here present, that was very, very careful. And he told me, I don't know what you have, and I will not give you any medication, and probably I will not give you the answer you are trying to have, because it's true. Okay, I've got an inflammatory process, huge inflammatory process, and at the beginning I don't have any markers for a syndrome, an autoimmune syndrome, but perhaps at the end it will come to that end or not. I don't know. He will probably tell me some years later or sometimes.
Do you experience post-exertional malaise?
Yes.
Yeah.
Yes.
So like coming here today, you'll be in bed for a couple of days.
I had difficult to do any kinds of effort. Yes, I do, but with a lot of consumption of energy and with very difficult, even in spoken. At the telephone, it's awful for me to spoke. It's very difficult.
And too much stimulation, like listening to TV or even the lights.
Yes, lights is horrible. And I had before headaches when I was young. Afterwards, I stopped having headaches. And with the infections of COVID, headaches turn on again and worsen even more. And coming back again to what you are asking me, Susan, now about the neurologist. Meantime, one time after the COVID, I had similar like an ischemic transitory accident. 2 hours without even can spoken everything. I didn't know what it is. I didn't know what a glass was. I didn't name water. Right. And I went to the hospital. I do MRI, and they didn't know what it was. The MRI was okay. Normal. Right. And they proposed me to start on statins and on aspirin. Right. I didn't start both because I had myalgias. And statins is
Can you just
yes, can agree more, and I stayed like that, and I as a physician, not as a patient, because it's difficult to adequate both. I thought it was more a complication of long COVID, right? And it's past 2 years, and I'm equal, never get again.
You haven't improved at all? Have you had any days where you almost feel your old self?
Some days I feel it's all better. I'm as new. I don't feel any pain. I can do all things, and next day I wake up and it's awful again. Right. It's awful, and even worse the day afterwards.
Do you feel, despite your daytime fatigue, that you have trouble sleeping?
Yes. The sleeping is not recomfortable. No, not no recomfortable. The day afterwards, it's.
And do you get temperature dysregulation? Do you feel excessively cold or hot? None.
Oh, I've been all over my life. I've very cold. Yes.
Yes.
This not.
And now you had told me you got it a total of 5 times.
5 times, yes.
Were there any differences in the impact of the different infections? Like, was your first infection the worst one, or when you got it?
The first infection was the worst of all. It was very intense, fever, myalgia, headache, a horrible headache. I had a flu-like syndrome. Saturation was 89, 19 at home. I didn't went to the hospital because I know where were the hospitals. And bilateral conjunctivitis. Yes, an
you mentioned that.
Yes. And afterwards, I never recover the ophthalmological visual.
Do you have this as a side thing? Do you have home tests for COVID here?
Yes, we have.
And then you go get it you get a PCR at the hospital?
No, yes, the PCR, always confirm the PCR in the hospital. And the three other times were also symptomatic, and I feel all the prodrome syndromes, headaches, myalgias, and fever. Then I tested, and it was positive, and I stay home. And the last one was similar to the first one, and that's when I got myocarditis.
Wow.
It was last one in May. It's going to be 1 year in May. Afterwards, I stopped to test. Never more tests.
Did you get the vaccinations or the boosters?
Yes, I get vaccination. That was obligated here in Portugal 3 times vaccine.
Did you feel any effects of the vaccinations?
A little fever after vaccination, a little fever, and 1 to 2 days of myalgias. Only that, yes.
Okay. And we were talking a little bit in terms of past medical history. Do you have anything that you think would be a predisposing factor?
I think my medical history is a little bit difficult because I've got some other issues, but not correlated with this disease. But I have had before three or four. I think it was 3 times pleural effusion, pericardial effusion in contests. 1 time idiopathic and 2 times after an respiratory infection. That's why I suppose probably a connective tissue, an autoimmune disease in the past. In the past, no, that is not diagnosed.
You don't have any thyroid disease, Hashimoto's?
No. Thyroid, completely normal.
Hypermobility?
No.
No, we didn't talk. I don't think we mentioned that yet at the conference. Yeah. Okay. And any family members with autoimmune disease, your parents or siblings?
No, a cousin with psoriasis and I don't remember more. I don't think so.
Now, having had the experience from both ends, being a doctor and a patient, do you feel hopeful that you can convince the medical profession of the reality of the disease?
Yes, that's why I'm here. I hope that we can all make the difference because...
You're hired.
Sorry?
You are hired.
Yeah, okay, thank you.
I'm not going to pay, but nevertheless you're hired.
Yes, but I was not paid before for being tested.
Just kidding.
Yes. I hope we can do the difference because as a patient, I feel that we are not well supported. I feel that it's a disease that it's not well classified, well supported, well oriented, well treated. And as a physician, I think we don't know a lot of that. So we know a little bit, a very little bit, not only to diagnose, but to treat. And I think it's very urgent that we know how to diagnose. If there is no biological biomarkers, at least some keywords, some 4 to 5 clinical indications that, as you said before, 4 or 5 indications that we can do for at least 6 months, pain, disturbance in sleep, 4 or 5 criteria that makes diagnosis, we can help the patients to have a diagnosis and orientation and to give them a better life.
So we come to the end of this roundtable. Thank you very much.
Okay, you're welcome.
The idea here was that an expert to interview a patient so we can get a more personal feeling of what this means. Sometimes we're looking at groups of people with these studies and we lack the individual, the individual suffering, which was really why we designed this.